Well, welcome to Sign Out with the Professor. I'm very, very pleased again to have my dear friend and our special guest today, Dr. Zhongxin Yu. Dr. Yu is a professor of pathology at the University of Oklahoma and has expertise in pediatric pathology. She did her residency training here at the University of Oklahoma and then went on to the Children's Hospital in Cincinnati to do a fellowship in pediatric pathology before returning here to lead the effort for the Children's Hospital here in Oklahoma City. So with that, I'm going to turn the time over to you, Dr. Yu, to lead us through a number of interesting cases in your domain.
Hello, hi, good morning, everyone. Maybe good evening for someone. Today, I'd like to take this opportunity to share a few pediatric soft tissue and bone tumors with you. So those are most uncommon but important cases. I like to start with the first one. Clinical information is 11-month-old male have left axillary mass. The mass measures 1.8 by 1.5 by 0.7. It's not big. So the patient had the excisional biopsy. Here we have 3 slides, and they are all similar. So I start with 1 slide. Let me start the first one. So that's my lowest power view, 4x. So usually I like to evaluate a case, start with low power. Here's a low power. Look at overall. Of course, the black is our ink. That's like a fibrous tissue. Move around, you can see some pink, like a fibrous tissue. In the fibrous tissue, there is some like a more bluish small cells. So fat, pink fibrous tissue, and some small blue cells. Continue moving, and this really like we call the organoid arrangement. So like in their own compartment, mature fat, some pink fibrous tissue that intermingle with these clusters of small primitive cells. Background kind of little bit edematous or myxoid change. So let's move around. You go everywhere kind of similar. Here's entrapped, I think probably sweat gland, because in the soft tissue, that area, in the subcutaneous tissue. So overall, all the similar. So with this in mind, let's go high power look at some area. Yeah, I think that's classic. Try to focus on my screen. Again, so this is like a fibrous tissue, kind of bland, like a fibroblastic, myofibroblastic. Here, so you pay attention to small cells. And close look at those small cells. Yeah, spindly. And the nuclear contour is still very smooth. Although like a kind of primitive, there's not much mitosis. Those small cells are like inflammatory cells, those smaller one, like lymphocytes. I think occasionally we can feel these red blood cells, maybe eosinophils. So this overall also primitive, but do not have like a very typical malignant looking. So that's a small cell area. And closer look at this more pink area. More pink, kind of more like a collagen-like. So the pink is fibrous tissue, the fibroblast or myofibroblast. So that's overall pink area. And this is fat area. So the fat is mature, like a nuclear on the edge, and there's no, there may be a very kind of, looks like we call pseudo lipoblast, because little the nuclear here, cytoplasm, but overall it's kind of mature. So with this, like we call the triphasic tumor, have fat, have like relative mature myofibroblast, have immature tissue. In 11 months, or like an infant, in a boy in the axillary soft tissue, what the differential is? Anyone want to give a diagnosis? The clinical presentation is classic. Usually it's boy, usually it's axillary. Also can happen in other locations, can happen in the girl. And the histology, the triphasic organoid arrangement. It's uncommon, but the name is fibrous hamartoma of infancy. So it's fibrous, because organoid arrangement we call it like a hamartomatous, usually happen in infant. So we call fibrous hamartoma of infancy. This is a benign lesion. The reason I like to show is just do not mistake for any like malignant tumor because of small cell area. So remember the classic clinical presentation. Remember this like triphasic arrangement, histology, and overall blend histology, and the diagnosis usually do not need any additional workup. There's a slight recurrent rate, probably 20%, but sometimes it can regress on its own. So just observe, try to completely excision and watch.
So Zhongxin, is this related to fibromatosis that we see in adults?
No, it's different.
Yeah.
Different. Yeah, it's not. Beta catenin usually negative. Usually not very aggressive. Yeah. But you know, it's an infant. The family may like really worried, have a tumor. So they want to know the rapid diagnosis. So when we get this, we can make a diagnosis. Usually when we see the tissue, usually make a diagnosis immediately, usually help. Let me see, there's in the chat. Let's see. How can I open the chat?
Oh, yeah. So that was one of our participants just thought it might be fibromatosis. That's why I brought that question in. Yeah.
Anytime we encounter those fibrous tumor, we always want to rule out desmoid fibromatosis. This is not, but there are some others may related to that. I have a few other cases to show in the young child. This one is just like we call it hamartoma. So it's benign. Let me see, I think. Right now, there are some gene, probably like EGFR mutation. You can, if you have trouble, if the lesion is large, you are not sure, you can run NGS. Recently, they found EGFR exon 20 insertion or duplication can find in this tumor. So if in doubt, do NGS testing. Majority time is small, you do not need it. Dr. Hassel, you will watch the chat for me, right?
Yes. I'm monitoring for questions or comments, and I'm putting in a few transcripts where the auto transcribe didn't quite capture the right term.
Okay. Any question on this case? If no question, we can move on to other. Small lesion, but important. And also because characteristic histology, often this tumor show on the test, like take a board or something, they like to show those kind of classic case. Whenever we talk about fibrous hamartoma of infancy, I like to compare with another similar lesion, also in infant, but histology is a little bit different. Here's another one. This patient, a 1-year-old male, is left finger volar mass. The tissue we received is how big? Because excisional biopsy is 2.1 by 1 by 0.4 centimeter. So it's not very big. Here is the slide. Again, I start with low power here. So in the lab, they receive with a series section, put them together. So you can see at the low power, there's kind of pink fibrous area. There's some mature fat. We did not see those like a perimeter small blue cell area on this field. So keep moving here. Like a biphasic, this one, like a more pinkish fibrous tissue or myofibroblast. Here is fat, like a mature fat. No, like a small blue cell area. This is another piece. Similar, we call it like a biphasic. Remember, previous one we called a triphasic because small blue cell area. This one is more like a biphasic. Mature fat and fibrous tissue. So you look at the overall every area. They are similar. So let's go high power look at one piece. So this is like a spindle cell, fibrous myofibroblastic proliferation. Those like mature fat. And in the fibrous tissue area, you can those like have vacuolated cells. We call the pseudo-lipoblast. And this area is mature fat. This is like a myofibroblasts. If we do SMA, those cells are going to be positive with myofibroblastic staining pattern. And those are fat. Sometimes if a little bit of this, you are very confident in the pseudo-lipoblast. But sometimes we have to put that if this real lipoblast or not, we can do S100. Those areas usually negative. If this have too many, make you worry about lipoblastoma, we may go ahead to do like a FISH for plug 1 to rule out lipoblastoma. But overall, in this case, it's like more like a biphasic tumor, what we call the lipofibromatosis. You have lipo, you have fibrous tissue, lipofibromatosis. Usually in young child, like a 1-year-old infancy, this recurrent rate is high, probably up to 70% case going to recurrent. So recognize this diagnosis is also very important. So always whenever we talk about the fibrous hamartoma of infancy, we like to compare to the lipofibromatosis. So lipofibromatosis. Again, this one usually negative for beta-catenin. So it's not a classic for adult desmoid fibromatosis, and usually happening in children, young infant. So that's another case.
Is this location characteristic for this lesion on the hand?
No, hand is not characteristic. Trunk more characteristic, and head and neck is more characteristic. This one just happening in the hand. Yeah, lipoblastoma, anytime you see those vacuoles, you worry about the lipoblastoma. Lipoblastoma usually do not have this prominent fibrous septa. They usually thin fibrous septa, not like this, like a biphasic, almost half kind.
What about differentiation from, say, a spindle cell lipoma?
CD34 usually negative.
Okay.
Yeah. Spindle cell lipoma also usually happen in adult.
Right.
Yeah. Children, we usually see children have more soft tissue tumor than adult. Only since we have less lipo tumor, like a lipoma, less regular lipoma. We do not have many as adult. A spindle cell also can. We do have it when we have some syndrome, but in general, less lipo. Only have a few lipo tumor. So any question on this one? Lipofibromatosis. It's also a WHO recognized diagnosis. Recurrent rate is high. And right now, there are some gene tests. Before, we usually don't do genes. Now, NGS, they identify so many genes. This one seems associated with FN1 mutation with some partner genes. So maybe you can do NGS, find some genes. Majority of the time, we do not do that. When we receive those kind of cases, we will do CD34, we do S100, beta-catenin, those kind of markers. And also make sure it looks not like malignant to atypical the cell morphology. Lipofibromatosis in infant. All right. And also we do SMA to confirm those fibrosis myofibroblastic. Talk about infant tumor. I have another infant tumor on the finger. This one, I really like it, very cute. This one is 1-year-old boy. Is the not the finger, this one the toe, left toe, mass, excisional biopsy. The tissue we received is multiple fragment, 0.6 to 1.5 centimeter in grid dimension. So submitted entirely. So this multiple piece. That's my low power view. Very fibrostic looking. So those are like adnexal structure, entrapped, not distract, but entrapped. Means the tumor grows very slow and probably benign behavior. And this is like a very fibrotic pink. That's the skin. So epidermis normal, the tumor is kind of like a dermal based. Expansion of this dermis all the way into the subcutaneous tissue. So pink fibroblastic tumor. So keep looking. They are similar. Again, demonstrated those adnexal structure. This is the tumor. This is relative normal dermal collagen here. So a little bit different. Normal collagen is hypocellular and pink, and tumor is more proliferative, have spindle cells, myofibroblastic appearance. I will go high power show you. Again, this piece. Okay, let's go high power look. Again, those fibrous tissue, the bundle, kind of the arrangement, kind of this is skin surface. Those fibroblasts grow kind of perpendicular to the surface. A little bit warding some area, and that's adnexal structure. So that's the kind of very bland. Spindle cells, background kind of fibrous tissue. Let's look. Usually do not have much mitosis, but occasionally may have mitosis. So this morphology probably kind of looks like adult desmoid fibromatosis, myofibroblastic proliferation, those pink cells, plump spindle cells, nuclei. But if you think about this case, it's on the toe, sometimes in the finger, as characteristic location. It's infant, 1-year-old, young infant, finger or toe. Make you think about fibroblastic proliferation with this kind of morphology. There is one thing you have to remember on this lesion. So go higher power to looking. That's my 40x. What did you see? In addition to those spindle cell nuclear spindle cell like plump nuclei. This is probably a mitosis. And fibrous background. And there's something interesting. Did you see those round structure?
Yeah, you've got a lot of eosinophilic droplets of some sort.
Yeah. Those eosinophilic droplets inside the cytoplasm, actually. Some is in a perinuclear. Let me see this perinuclear one. Go high power. I can go to my 60x. 60. Okay. So now you see more clear. This characteristic for this lesion. Anyone want to make a diagnosis?
Can I guess
Yes.
that might be inclusion body fibromatosis?
Very good, very good, very good. Yeah, WHO called the inclusion body infantile digital fibromatosis. Very good, very good. This is diagnostic, those inclusions. And those inclusions, in some lesions, there are many, sometimes rarely find. This one, we are lucky to have so many. If you think about this diagnosis, sometimes if you not see good on HE, and you can do another special scan. Which special scan do you like to see? To help find those inclusions. One special scan, not immuno. Immuno can help, but we usually do special scans. Can help you diagnosis. Here, well, this scan is
Trichrome?
trichrome. The trichrome, the blue, you stand to background collagen, fibrous tissue, and they also highlighted those inclusions area. So many inclusions.
Yeah.
Here or clear enough, right? Those inclusions. Better, can make it better. So why trichrome highlight those stuff? Because this inclusion is degenerative or change. It's an actin related material. So trichrome stem muscle red, collagen blue. So those are like actin material. So by trichrome, those inclusions are red. And people may ask, how can you compare this? Why this is not red blood cells? Red blood cells, you can find some contrast. Red blood cells usually uniform in size, not like this, variable, large, small, tiny. So this is different from red blood cells. So very cute. But if you see this, it's, oh, I can make a diagnosis and you feel good. And digital inclusion body, digital infantile digital fibromatosis also have a high recurrent rate. Sometimes they think they did excisional biopsy, but still have some residue, may come back, and just tell the surgeons that this is benign, recurrent rate is high. If recurrent, conservative for re-excision. So it's not malignant, although recurrent. So it's good disease to make a diagnosis. Any question about this? Inclusion body infantile digital fibromatosis. And this one also beta catenin usually negative. If you want to do immuno, you can do SMA. Those inclusion body also SMA can be positive because actin material. I think I did actin, let me see. See if it works or not. Usually do not need to do this much, but sometimes to confirm or teaching purpose, I do a few additional. So fibroblast on the background, spindle cell positive, and those round nodules also positive. Inclusions also positive. Any question about this? Infantile digital fibromatosis.
Is there any genetic or syndromic association with this lesion?
So far, I have not found any recurrent genetic change. So far, I have not. And this usually in infant, I think there's rarely reported in adult, in extra digital location, very rare. Majority is in the digit location, either toe or finger. Usually small nodule, usually in infant, but always have exception.
Yeah.
Yeah, find this inclusion is the key for the diagnosis. So do trichome. Continue. Okay. All my this group of case in the infant. I have another infant, 1 year old male, have a back lesion. It's a paraspinal, kind of plug-like thickening lesion. So they did a biopsy. The biopsy called the gross dictation said 1 by 0.7 by 0.3 centimeter. I think this is probably incisional biopsy, usually bigger than this one. So of course, serious section. In the lab, we always ink. So the blue is our ink. So this pink area is our lesion. So multiple piece here, low power view, that's similar. Pink. Very bland, very bland. So multiple pieces, they all look similar. So let's go high power look at the one of this piece. What did you see here? Very hypocellular. There are few vessels here, and a very small nuclei here, and majority of the collagen. The collagen kind of arranged a hyperhazard, we call it. And there's a cleft, we call the cracking artifact. So cracking. Higher power. So majority of the lesion composed is like a collagen, hyperhazard arranged collagen with a small, tiny spindle nuclei. There are some vessels here. Not much inflammation, no like pleomorphism. It's my 40x now. No inclusion. So that's basically what we have. Very bland, very benign looking. People may think that's probably normal tissue, but it's not. Anything you can think about with this kind of morphology?
So I'd wonder about a P10 syndrome, like a collagenoma or something of that sort.
Yeah, great. That's definitely in the differential. Yeah, that's definitely in the differential. There's something else.
I think it can be a Gardner fibroma.
Very good. You have a very, very great group. This is a classic picture of Gardner fibroma. The usual in the sometimes infant, sometimes older a little bit. The can be head, neck, and other location, but the most common in the back, perispinal plug-like lesion. Very deceptive on the histology. Some people look like this. Oh, that probably just fibrous tissue, maybe normal tissue. Maybe the surgeon take the wrong tissue. Some people may think about this. But interesting is, those hyperhazard arrangement really is kind of unusual. A normal tissue, not like this hyperhazard like bundle. very hypocellular. The most important thing is to think about this lesion. If you think about, you can do something addition. What are you going to do to confirm it? Yeah, this is a Gardner fibroma. And in adult, proper kind of nuclear type of fibroma also have a similar morphology, hypocellular, collagen, hyperhedral arrangement. But if in children, you definitely want to rule out Gardner fibroma because Gardner fibroma may be the first presentation for APC gene germline mutation. So they need to do the gene test to monitor the colon cancer or something like that. So probably this sometimes they be a sentinel sign for Gardner syndrome. So very important to recognize. At least you need to rule out it. So if you want to do some immuno, what do you want to do? Anything can confirm it? Because Gardner fibroma associated with APC gene mutation. Any immuno can help. I have an immuno here. Those nuclear positive. Remember, this is hypocellular, not many nuclear, and nuclear are small. So these are the nuclear, they are positive. Associated with APC gene mutation. What this? Beta-catenin. Beta-catenin positive in Gardner fibroma. So if in doubt, do beta-catenin. The majority of them should be positive. If negative, you still should make a comment. You see, you looks like a Gardner fibroma, although beta-catenin negative, and recommend clinical workup. Correlated with the clinical history, maybe family history of colon cancer. If you really want to do additional, you want to do APC gene mutation test. So we always make a comment like this. This one positive, we more strongly suggest, or we just go ahead diagnose Gardner fibroma, recommend clinical correlation. If negative, comment, say, you need to work up, we cannot rule out. Majority positive, but there are negative cases. So positive help. Gardner fibroma, very bland, very deceptive. But just remember this diagnosis, really helpful, especially for the family counseling for the future workup. Pediatric pathology, sometimes we have majority tumors like benign, but some tumors just like this, although benign, but have significant clinical indicator for family workup, for genetics, for like a cancer predisposition syndrome. So it's important to recognize, make a appropriate comment, give a recommendation for clinical workup. So benign lesion, but important. Gardner fibroma. We can go to another case. Any question about the Gardner fibroma? If not, I go another case. 6 months old, younger, 6 months old male, mass in the left temple, so in the scalp. Excisional biopsy, the tumor is 2.7 by 1.5 by 1 centimeter. It's not too big. So this is selected case. So that's skin. That's normal collagen. Kind of like our Gardner fibroma. These are normal collagen here. But this, intermingled with this adnexal structure. This is our tumor. So it's kind of relatively circumscribed on the edge. But here, extended into the surrounding fat. So deceptive growth looks like a circumscribed, but the microscopic, you can see the fibrous tissue stick out. So that's a residual fat, normal fat. So that's the lesion. Again, it's kind of fibrous proliferation. So like vessels here, and the spindle cells, fibrous background. Nuclear kind of a plump. So I don't know, if you do adult pathology, it's kind of mimicking adult desmoid fibromatosis. And look around, you can see some area. A little bit myxoid change. With some red blood cell extravasation. Red blood cell extravasation, hemorrhage, a little myxoid area. So in the young infant, in the scalp, myofibroblastic proliferation, there are of course always a big list of differential, but if in this category, there's one lesion definitely come into a differential. Anyone can give differential? Spindle cell, myofibroblastic proliferation, little myxoid, extravasation of red blood cell. In the temple, in the head, scalp. We can do immuno. This one immuno is partly for beta-catenin. And we can do molecular. Molecular, we can do fish. Fish is partly for USP6 break apart. Diagnosis. Perennial fasciitis. Kind of in the nodular fasciitis category, we all have a USP6 mutation, break apart, fish can confirm it. And also have the extravasation, usually happening in the infant, in the cranial. That's why we call cranial fasciitis. Different from regular nodular fasciitis, is nodular fasciitis usually beta-catenin negative. Infantile perennial fasciitis usually beta-catenin positive, and usually more aggressive, and sometimes invade the bone and really mimicking malignant. We had one case before, I cannot find that case. It's very like a typical nodular fasciitis appearance, like I have a I do not have it. Usually feathering, spindle cells, hemorrhage, prominent mitosis. Really think about the malignancy. But if it's the infant in the like a young child in the head, remember this diagnosed differentials, perennial fasciitis. If you have beta-catenin, do beta-catenin immunostance, or you have for fish, you can do USP6 to confirm it. So this is a benign lesion. Also, image clinical looks like very aggressive. Still is a benign lesion, conservative for treatment. So just remember this category, cranial fasciitis. Any question?
Do these ever spontaneously resolve? Sometimes
usually
nodular
not.
fasciitis will spontaneously resolve, but
some can spontaneously resolve. The majority they need to go because they are so aggressive. They often want to do something. The majority go inside to try to do excisional biopsy for us to get the tissue. Once we get a tissue, they observe. Also, there are some residue, just like a nodular fasciitis, and they probably become scar. They usually do not come back. I think clinical history, clinical progress is similar to nodular fasciitis. Just at the time of presentation is more aggressive. And the only thing different is beta-catenin usually positive. cranial fasciitis. Any question? Okay. Question. We get a case like a relative older patient, 3-year-old. 3-year-old in the lower abdominal mass, soft tissue mass. The tumor measures 6 by 4.6 by 2 centimeter, kind of large, 6 centimeter. So the initial did a biopsy, frozen section, then did the excisional biopsy. So I show you this case. So it's big excisional biopsies. So this is skin. So epidermis looks normal. Superficial dermis in this slide looks relatively normal. You continue moving. So in the deep dermis, there is some spindle cell proliferation here. That's a low power view. And very loose, some myxoid background. Small myxoid area, low power. Big lesion. And even in low power, you can see something here. Some giant cells. That's a giant cell. So those nuclear, like multinuclear giant cells, some indentation, and background those fibrous tissue, so spindle cells. So majority of cells like spindly produce collagen, fibroblastic, myofibroblastic proliferation with some giant cells. That's majority of this lesion. This area show you giant cells. That's giant cells. So background tissue, again, spindle cell produce collagen, kind of myofibroblastic or fibroblastic lesion with some vessels here. And also scattered inflammatory. So those are lymphocytes in the background. All over the lesion. Inflammatory cells. Those giant cells. So remember the giant cell. The giant cell come with your diagnosis. This one, another one, 2G. So that's the use more solid area. And there are area we take a kind of cystic change. I'll show you in this slide. Oh, here. Kind of like a cystic space here. Like a cystic space. Those cystic space lined by occasional those giant cells, spindle cells, they are not endothelial cells. So we call the pseudocyst. The cytic lining cells is similar to the background of those cells, spindle cells, and occasionally those large giant cells. And if we want to confirm this is not endothelial cells, you can do CD31. CD31, these cells are negative. And before I tell you another immunos, if you have, let me know if any differentials now. It's young child, a 3-year-old, and have deep dermis, there is more cellular area. The deep dermis, big mass, have myofibroblastic proliferation, some giant cells, some pseudocyst, background have some chronic inflammation, like these plasma cells. Plasma cells. So what's your differential? Or you want to do what immuno you want to do? Because this immuno really helpful if you are thinking in that way, the diagnostic way. Those just vessels. Here is not pseudocyst. This is endothelial cells.
What about ALK?
ALK, it's good salt. It's good salt. ALK, you can have like a mixed solid change, but ALK usually do not have the pseudocyst. Usually do not have those giant cells. The giant cell is characteristic for this diagnosis. We can do ALK immuno is negative. It's good salt have inflammation, myofibroblastic proliferation, definitely is good salt. Something related to the giant cell. Oh, there's another pseudocyst. So those giant cell. This is thing we call the giant cell fibroblastoma. Giant cell fibroblastoma is a variant of DFSP, dermatofibroma protuberans, dermatofibrosarcoma protuberans. It's same family, but usually happening in children. And they are all have same genetic change, same immuno profile. CD34 stands strongly positive. And you have same Coli A1 and what's another gene mutation? PDGFB fusion. Same gene, so it's the same family. So this is why I did a CD34. I want to show you. Strongly positive. So not only this spindle cell positive, I also like to show you those pseudocytic lining. So those lining cells are also positive. Lining. And those giant cells are also positive somewhere. I can see. Yeah, it's called giant cell fibroblastoma. Similar behavior as DFSP, but usually more mild progress. Total excision is the treatment of choice. Usually, sometimes this lesion can have overlap with DFSP in the simulation. Some area like a area of classic DFSP area, like sharp transition. Sometimes like a gradual transition. But the important thing is recognize this lesion is not malignant, especially for this one, like 6 centimeter. So they just follow up. I think there's some treatment for this right now, like a targeted treatment, just like a DFSP. If we total excision, there's no worry, and follow up recurrent. And of course, recurrent can have either same morphology or have a classic DFSP morphology. And also need to worry about, if recurrent, worry about fibrosarcoma, malignant transformation things. But in general, it's mild prognosis compared to DFSP. So recognize the large giant cells, recognize those pseudocysts. It's fibroblastic proliferation. It's in the children, usually young, can up to like a 7-year-old. And also those kind of cases come in cluster. We have like a 1 year, we cannot see one. There's 1 month, we see 3 sometimes. This one is 3-year-old. I think next week I saw like a 7-year-old simulation. All right, that's giant cell fibroblastoma. Usually it's dermal based, deep dermis or subcutaneous tissue. Usually not in the very deep soft tissue. cell. Okay. Another young child lesion. Maybe give you the older child, 17-year-old. A 17-year-old have distal lateral thigh mass. The mass is 3.7 by 2.3 by 0.9 centimeter. So totally submitted, and this is one of the 17-year-old. This tumor can see in children and adult a little bit. As I said, in children, we do not have much lipo kind of tumor, lipogenic tumor. This one is kind of low power view. That's mature fat. True fat. And that's more cellular area. And some cystic degeneration, like a pool of mucin. That's more characteristic area. In this area, not much adipose tissue. Mainly is fibrous tissue, mucin pool, and some vessels here. Same area, it's mucin. And the vessels have so many vessels. I don't know, I think probably those are pink area as vessel, like a thin walled vessel, angulated. Sometimes we describe this as the chicken wire vessels, angulated chicken wire vessels. So in a 17-year-old soft tissue mass with this kind of morphology, and close look at the cells. Cells are spindly. Now we can see those pink vessels more better here, like a thin walled angulated vessel, or those pink lines vessels, and we call this chicken wire appearance. And the very mixed background, even for mucin pool. The cell morphology very bland. The nuclear, not much mitosis. So spindle cells, small primitive cells, myxoid, chicken wire vessels. What's your differential diagnosis, or what's your diagnosis? Older children, now it's 17-year-old. That's the mucin. The mucin pool, sometimes we call the pulmonary edema-like. Mucin material. Those pink are vessels. Pulmonary edema-like mucin material. And very bland cytology. And there's some fat here, like a relative mature fat. Let me find if any lipoblast. Oh, here. There's more like a lipoblast. More like a syngnathrine-like lipoblast. Variable stage. This is like a mature fat, probably. That's more mature. And that's smaller. Some lipoblast and myxoid, chicken wire vessels, very myxoid. Anyone want to give a try? Myxoid liposarcoma. Because the patient age is older. And we go ahead, did a DDIT3 break apart. It was positive. Immunostat usually do not help. The diagnosis, let's see, myxoid lipoblastoma, majority is well differentiated, low grade, like this one. There are sometimes you have for small cell component, very hypercellular, round cell. If that area more than 5% overall, the lesion we call small cell variant. They have the same genetic change, DDIT3 fusion with other partners. And that one, small cell variant usually like more aggressive. The majority is like this one, like a well-differentiated, low-grade, myxoid fibroblast. So myxoid liposarcoma. And if you think about this lesion and do FISH, the diagnostic features not rely on those like lipoblast. It's rely on those like chicken wire vessels. That's a diagnostic feature. Myxoid plus chicken wire vessel. Always think about this tumor. Looking for those lipoblast, even though you not see it obviously, especially specific if you do a core biopsy, you may not get this part. Still think about myxoid chicken wire vessels. Think about this diagnosis and do FISH test to confirm. So this is usually in the older people, older children or young adult, or sometimes happen in older adult. So similar morphology. I use this case once you introduce another tumor, similar morphology, but it happened in the infant. That's another case. This case happened in 1-year-old, big mass. We received a tumor measure 13 by 6 by 2 centimeter, kind of large. So in the, I don't remember in where, a red buttock. So similar morphology, but in the young child. So low power view, you can see this is like a more mature area, kind of that. There are area like a more cellular spindle cell. And in the spindle cell, you have more fibrous tissue intermingled with fat. Continue moving, there's more cellular with myxoid background. The chicken wire vessel is more prominent, easily see here. Chicken wire vessel, angulated vessel, connection network, and myxoid background. This way I do not have a pulmonary edema-like area. What I have is more like a myxoid and chicken wire vessel. If this in the older children, like a 15-year-old, 17-year-old, I would consider this could be well-different myxoid liposarcoma. But in this is very young, and the likelihood is lipoblastoma. Lipoblastoma and the myxoid liposarcoma, there are some morphology overlap. I have CK's lipoblastoma have a mucin pool, like a pulmonary edema-like area. And lipoblastoma also can occasionally have a rare mitosis. And they all have feature, have a myxoid change, have chicken wire vessels. The only thing genetic different. Lipoblastoma have a PLAG1 mutation, either amplification or rearrangement. Myxoid liposarcoma have DDIT3. Lipoblastoma is a benign tumor. Myxoid liposarcoma is a malignant tumor, so should be tell this apart. So the key diagnosis feature right now is age. If it's a young infant, 1-year-old, 2-year-old, even 3-year-old, think about lipoblastoma. If older children, teenager, young adult, myxoid liposarcoma. So always these two put in differential and young based on morphology, based on age and the molecular testing. So very important.
Yeah, that's a great contrast to be aware of, and obviously a pitfall. If you don't know the history or the age group, you could easily get led down the wrong line.
I think time is up, Dr. Hassel.
Yes, yeah, this has been a great session. Are there any last questions from our participants you want to ask Dr. Yu? If not, if something comes up later, certainly don't hesitate to reach out, but this has been a great session. I've learned a lot, and I suspect that our participants have enjoyed this greatly. These are great cases and very important differentials to be aware of, and not necessarily the sort of thing that we see routinely in the adult world by any means, but certainly have some bearing for the general pathology practices out there. So thank you very much, Dr. Yu, and thank you to our participants for joining, and we will see you next month for our next session. Thanks very much.
Bye-bye.